Okay, so the first thing we're going to do is how to open an airway. So we need to do either one of two procedures. A head tilt chin lift, that will open the airway up, and then we can look, listen and feel for normal breathing. Or we can do a jaw thrust. Now, doing a jaw thrust, we would use this technique if we didn't want to overextend somebody's neck. So what we actually do is we displace the jaw and bring it forward, which actually opens the airway. So to do this, you need both hands on the cheekbones and 2 fingers behind the angle of the mandible. And we're actually going to displace the jaw and bring it forward. So essentially, you're bringing the bottom teeth in front of the front teeth. Now, this is a way of opening the airway, as I said, without actually overextending that neck. And especially for people who've got spinal problems, or maybe if they've got Down syndrome, we should never overextend the neck of patients who have got these conditions. To clear an airway, so if we've got vomit in the airway or a lot of saliva, we could use suction. So we've got every single ward and area should have access to a ladle suction unit. Now, these should be plugged in at all times, so never ever turn the plug off. They should be kept switched on, because what they're doing is they're charging while you're, going about your everyday duty. So what we would need to do is we need to switch the suction up to around 200. We don't need to go right onto full because it's very, very powerful. Obviously, all the tubing and the suction tip will be in packages. You mustn't open your packages ahead of time because obviously dust can get in there. But once your suction is on, we can then suction into the patient's mouth. Now, make sure that you're not going in blind. You need to be able to see where you're going, because the last thing you want to do is to go too far back. We'd recommend that a maximum suction of around 10 seconds for an adult and 5 seconds for a child. So 10 seconds in, nice gentle sweeping movements to remove the liquid, and after 10 seconds we go back out, and then we can go back in again if we need to. For solid objects, in your kit you should have a pair of McGill's forceps. Now, as you can see, these are angled and they've got a round edge, and they've also got a serrated edge. So if there is something that is stuck in the back of the throat, we can actually get the item out with these rather than actually putting your fingers in there. So again, do not go in blind. We need to make sure we can see where we're going. We can grab the item and pull that out. Once these have been used, these can go straight into your sharps bin and you would need to replace them. They're not for sterilisation. Okay, so the next thing we're going to talk about is maintaining an airway. So we've got a couple of simple airway adjuncts in our resus kits. We've got oral pharyngeal airways, which are also called Goodell's, and we've got nasal pharyngeal airways, which go obviously into the nose. I'm going to talk to you about oral pharyngeal airways first. Now, most areas have got 3 sizes. In areas that see children, they do have smaller sizes as well, but the actual way of measuring them is the same. So what we need to do is we need to measure the flange, which is that part there, the round part, against the lips, and imagine if that was to sit in their throat, it would go into the airway, and as you can see, that looks about perfect for that mannequin. Now, if you put one in that was too short, what would happen? The tongue could thrust it out of the way, so it would be useless. So it's actually better to go slightly bigger than smaller. So once you've got the correct size, what we need to do is insert it. Now, we always insert it with the curvature going upwards. So we open the airway, that head tilt chin lift, and we put it in with the curvature going up, and just before we get to the palate, we turn it 180 degrees, and that then sits behind the tongue. If you see vomit or saliva in there, we can still suction down the sides if we need to. To remove the Goodell, so say the patient had a cardiac arrest and we got return of circulation and they were starting to gag, we would remove it the way that it's sitting. We don't need to turn it. Okay. So the next airway we've got is a nasal pharyngeal airway. Now, we have 2 sizes in all of our areas. We have a size 6 and a size 7. Most adult females would be a size 6 and most adult males would be a size 7. But of course everybody's different heights, so we may have a really tall lady that you could use a 7, and vice versa, you could have a smaller male where we'd use a 6. But a way of checking the size is to measure from the nose to the tragus of the ear, so that little bit there. So if we look at this mannequin, we can measure, and that's about the right size for this one. Now before we insert this nasopharyngeal airway, it does need to be lubricated, so you should keep some Optilube or similar water-based lubricant with your emergency kit, and they should be stored with your nasopharyngeal airways. What you would do is open the package and you'd put a blob of the lubricant on the top of the airway and pull the package over the top so the whole thing is lubricated. Now I've already lubricated this with some special mannequin lubricant. So to insert it, we pull the nose up and hold it quite close to the tip so you've got loads of control. If you're up here, it's very bendy and you're going to struggle to have control of it. So if you hold it close to the tip, it gives you more control. So pull the nose up and the slanted part goes towards the septum. Now remember, we want the airway to go down into the airway. We don't want it to go upways, so we need to imagine where we want it to go. So we can either wriggle it in like so, or we can pull it back and push it in. Now if you come across resistance in there, so maybe there could be a polyp in there, or if you see blanching or you struggle to get the airway in, then do not force it. Just take it out. You could try the left nostril if you wanted to, but if not, you could take it out and just go and use a different airway. I wouldn't recommend, if you've got a patient in a cardiac arrest and you've actually used a nasopharyngeal airway, even if they get return of spontaneous circulation and they start to come round, that you remove it, because these actually act as a plug, and as you can appreciate, there's lots of little micro blood vessels in the nose, and it could activate a nosebleed by removing it, so let the paramedics do that when they arrive. Okay, so now we've got an airway adjunct in place, we're now going to use some oxygen. So this is the system that we would use where a patient's not breathing or not breathing normally. And this is called a bag valve mask. Now as you can see, it's got 3 sections. It's got the mask part, it's got the bladder, and it's got a reservoir bag. Now inside the package, when you get it out, you need to make sure that the tubing is attached to your oxygen cylinder. You need to make sure your oxygen cylinder is switched on, and then we need to turn the flow meter up to 15 litres, which is full. Now this is a 2-person technique, so one person needs to hold the mask in place and a second person needs to squeeze the bag. You should never ever try to manage this on your own in a real life situation. So I'm going to hold the mask into place, and if my assistant Candice can come and help me please. So can you press it twice? Lovely, thank you. So after the 2 breaths, we would then go back to compressions. Okay, so next I want to talk to you about a more advanced airway that we've got in most areas. These are called an i-gel airway. Now they come in a resus pack just like this. As you can see, there is the i-gel at the top in a cradle, and inside there, underneath, there is a head strap, a sachet of lubricant and a suction tube. So that's what they are presented like. So when you look in your resus trolleys or your emergency bags, you will see these. Now they come in 3 different sizes. They get a 3, a 4 and a 5. So they go up in weight. Now this one is the number 3 is 30 to 60 kilograms. The size 4 is 50 to 90, and there is a 90 kilogram plus, which is the size 5. Now most normal adults will be a size 4. So if you've got a casualty that is a general normal size, this would be the i-gel to pick. Okay, but obviously if you've got a patient that is bariatric, who's always very, very large, it would be worth going for the size 5. And then for the size 3, you could actually use these in most children over 11. Most children will weigh over 30 kilograms, so it is useful. But then you've also got your very petite, small people that you could use one of those on. So to use an eye gel, again, like I said, you have to be completely unconscious, not breathing normally. So you've got to remember that compressions are going to be undertaken. So if we imagine that compressions are going on now, what I'm going to do is I'm going to take the eye gel out of the cradle. Now I'm not going to hold it anywhere lower than this part here. We want to try and keep this area as sterile as we possibly can. Next, we need to use the lubricant. So what we're going to do is we're going to put a blob of lubricant onto the cradle. But I'm going to use mannequin lubricant. Yes. So holding the eye gel obviously in your gloved hands, what we need to do is we need to lubricate all of the green part and a little bit over at the top there where that's going to go across the palette. If there is blobs of lubricant on the eye gel, we need to scrape off any excess, because what we don't want is that to go down into the airway. Now before I insert it, I just want to show you the eye gel. As you can see, it's got a hole here. Now this hole, what that does is that covers the entrance to the larynx, okay? And then at the bottom there is an esophageal port, so that opens out into the esophagus. So these have been anatomically designed, and they are fantastic because they protect the airway from any gastric contents. So to put the eye gel in place, I would say to the people who are doing compressions, stop CPR for 5 seconds. That is all the time I need. I'm going to put the head in a sniffing position. So rather than a head tilt chin lift, we're just going to have it slightly tilted. And I'm going to hold the eye gel at the top and I'm going to push it into the throat until it comes to a stop. So now the eye gel's in place, we can get the other staff to carry on with compressions. Now what I need to do is I need to check that the eye gel is in the correct place. So what I need to do is to take off the mask off the bag valve mask and attach it to the top of the eye gel. Stop CPR just for a second, and as you can see, that is working. So I'd say carry on compressions, but what I want you to do now is I want you to do continuous compressions, please, and I am going to do continuous breaths. So once the eye gel's in place, this is where things change. You only need one person to manage the airway, and that's me, and you can do continuous compressions. So we're going to do continuous compressions, and I'm going to press this bag every 6 seconds. Now remember, the oxygen will be on, so this bag will be nice and full, and every time we press that bag, oxygen's going to be going down into the lungs. And we've got the continuous compressions, so this is the gold star for this casualty. Now what we need to remember is that in any cardiac arrest we're going to be using a defibrillator. Now I haven't shown you the defibrillator in this video, but we all should be aware that if you're using a defibrillator and it advises a shock, that oxygen must be moved away. So whether you're using the 2-person bag valve mask with the mask on, or whether you've got it attached to an eye gel, it needs to be at least 1 metre away when it's shocking. So it says shock advised, and I've said oxygen away, everybody stand clear, shocking now. As soon as that shock's delivered, it is safe to go back onto that eye gel again. Back to 1 breath every 6 seconds. Now sometimes you might see some liquid coming out of the esophageal port, which means that they've vomited. So what we could do is we can actually suction out of the eye gel down into the stomach with this suction tube that comes with the kit. So what you would do is from your suction tubing, you would put the we'd put the suction tube on the end of the tip, we'd get a sachet of the lubricant again, and we'd put a little tiny blob into the esophageal port, and then we could suction out of that there, which will actually suction any liquid that's come from the stomach. Once we start seeing the liquid coming up, we can stop. You don't need to keep pushing it in, else you'll go right down into the stomach. Okay, so we've got return of spontaneous circulation. So the patient's starting to gag. We need to remove this quickly. So what we would do is we need to suction on exit. So as we're removing it, we need to suction at the sides. So we basically pull it out and suction on exit.